So, okay, 1 second. Yeah. Good evening, everyone. It's always a pleasure to get back into the academic mode, and I would like to welcome all the participants who have been consistently with us the time we have started. Thank you very much for that. So for today's session, we're going to talk on Hfov, volume guarantee as volume guarantee, and Hfov as non-invasive mode of ventilation. So already I've started getting few questions. Maybe I will just forward it to our moderator, and then we can take up during the question time. So I would like to welcome our today's speaker, Dr. V C MANOJ from Kerala. He's the NNF president, Kerala chapter. Good evening and welcome from on behalf of NNF Karnataka chapter, sir.
Thank you very much.
Yeah, I would like to welcome Dr. Dinakara. Dinakara sir, he is the treasurer of NNF Karnataka state chapter and who has been instrumental in the webinar series what we have been doing now, successfully been doing. We would like to extend a warm welcome on behalf of entire Karnataka and entire India and all the fans across the country. Welcome, sir.
And Dr. Prashant, you tell about our joint secretaries, how much effort they are doing.
Yes, sir. Yes, sir. I would like to welcome our moderator for today, Dr. Abdul Razak, full-time chief neonatologist at King Abdullah University Hospital, Saudi Arabia. And he's our own guy, got trained from Bangalore Medical College, and he has completed his MBBS and master degree from Mysore and Bangalore, and completed his fellowship from Manipal. And then he moved to Canada because of his interest and passion towards research. And he has published a lot of articles, he has written many books, and he keeps writing. So it has become a norm for him. So we are very proud of you for making the entire Karnataka and entire India so proud with your work and research work. NNF Karnataka chapter would like to extend a warm welcome to you, Dr. Abdul Razak.
Thank you,
Dr. Bidri sir, please.
And we have our past president from NNF India, Dr. B.D. Bhatia sir, and Dr. Lakshman Bidri sir, and our present vice president, Dr. Kishore Kumar sir, on behalf of entire Karnataka, would like to give a warm welcome to as well. So today's session will be moderated by Dr. Abdul Razak. So I request Dr. Abdul Razak to give a brief introduction about our speaker, V C MANOJ, and then I request the session. Followed by that, I request Bhatia sir to give a brief introduction about Dr. Dinakara sir, and then we can start the session. Once both the sessions are done, then we'll take up all the questions and request all the participants to pose their question either to Dr. Abdul Razak or to me or to any of the hosts. We will be able to take up and take the question during the discussion time. Thank you. Over to Dr. Abdul Razak.
Thank you, Dr. Prashant, for the kind introduction. And hi, everyone. I welcome you all for joining this session, and it is glad to see you all. I'd like to thank Dr. Prashant and all members of NNF Karnataka for allowing me to moderate this session. Generally, the moderators have enough experience in primary research of the topic, and I'm in my early career, and I haven't done primary research in any of the topics that are presenting today. Nonetheless, I'm going to do a network meta-analysis in Cochrane, where nasal high-frequency ventilation will be one of the arms. And we hope to have some evidence and literature review by Dr. Manoj and the other speaker, Dr. Dinakara. So with this, I would like to introduce Professor V C MANOJ. We all know Professor V C MANOJ is the full-time consultant neonatologist at Jubilee Mission Medical College in Thrissur, Kerala. Moreover, he is president of NNF Kerala and IAP Neonatology chapter. So before I hand over to Dr. Bidri to introduce Dr. Dinakara, just a few housekeeping sessions on Q&A session. So if anybody has any doubts or any questions, please post in the Q&A session, Q&A box, and try to be precise as much as possible and try to introduce yourself so that it makes easier for us to answer your questions. So with this, I'd like to hand over to Dr. Bidri sir to introduce Dr. Dinakara sir. Thank you.
What yes, sir?
VC Manoj.
What yes, sir?
Yeah.
Yeah, please introduce.
Does Dr. Dinakar need any introduction? Dr. Dinakar, he has done his master's in pediatrics from KIMS Bangalore, and then he was trained in neonatal and perinatal medicine for 3 years at Edward Harriet Hospital, France. He has been executive board member of the NNF Karnataka. Presently, he is the treasurer of NNF Karnataka. Everybody knows he has been a great teacher. He has passion for the teaching, and he has been organizing chairperson for many national conferences. He has published many articles in index journals, and he is the one who has challenged the Bell's criteria in the NEC. Now, this was his formal introduction, but then Dr. Dinakar, I know him when I first met him as NNF president in one of the dinner meetings at the Bangalore club. And that was the time when I had identified that he is a person who is future of the neonatology at Karnataka. And then he is one of the rising stars in Karnataka. And he has the ability to carry everybody together. So that is a great quality in him. Now he is one person, you will remember that he brought the concept of subspecialty in the neonatology itself. He organized the neuroneocon and then gastroneocon and then cardiorespiratory and endo whatnot. So he's master in conducting the huge number of workshops, and that too with huge numbers, not 30, 40, it is in hundreds. He has revolutionized the NNF quiz, if you people remember. Now, when I was president, he was given this charge of reorganizing the NNF quiz, and he did it very wonderfully. Now, he's a great organizer of both events as well as the finances. At a very short time, he will arrange big finances for the big conferences. Sometimes he has to put in money from his own pocket as well. Neo Gurukul is the platform which he brought in for bringing all the academic activities related to newborn care under one umbrella. Now, he is the person behind the Neo Master E-classes. So, to summarize him, he is the great brain to think. He has great physics to execute, and he's a great teacher. So, these are my personal impressions about Dinakar. Thank you, Dinakar.
Thank you, sir. Thank you, sir. I request Dr. V C Manoj, sir, to start the session. Over to you, sir. V C Manoj, sir. Yeah, over to you, sir. You can start the session. Sir?
Can you
we
hear
can
me?
hear you. Yes,
Okay.
yes, sir, but voice is breaking in between.
Okay.
Now it's better. Now it's better.
Fine. Just start off.
Yeah, you can start the session, sir.
Respected seniors and my dear friends, at the outset, I would like to thank Dr. Dinakar, Dr. Prashant, and team NNF Karnataka for having asked me to give this talk, a subject that is dear to my heart. In the next 20, 25 or 30 minutes or so, I will try to impress upon you why targeting tidal volume should be the way to go in high frequency oscillation as well. We all know by now that there is no doubt that targeting tidal volume improves the mortality, intraventricular hemorrhage, BPD, PVL, pneumothorax, duration of ventilation hours, you name it, all the outcomes we now have enough evidence to say that but it's much better when you target tidal volume. Volume targeted ventilation versus pressure limited ventilation, there is no doubt. And the evidence is mounting. So In conventional ventilation, we have no doubt targeting tidal volume is a way to go, and that's what all of us do. But what about in high frequency oscillation? There's a new concept of targeting tidal volumes here. It's here also. So is it possible to target tidal volume? That is the first question that I'm going to address today. And then we will try to look at some evidence, very sketchy because this is a new concept, whether it will improve the outcome as well. Back to the basics. The ventilation means CO2 removal. That's how we teach, isn't it? So if you really want to have a gold standard for ventilation, it's alveolar ventilation. And in conventional ventilation, we all agree alveolar ventilation is actually practically can be measured only by the minute volume, which is which is measured, and then the dead space ventilation is minus from this. So we cannot, except under research, we cannot calculate the dead space ventilation. So probably what is happening is most of the time you take minute volume as a surrogate marker for alveolar ventilation, and then you deal with it. So this is what happens. So and it is reasonably okay if you set your targets well. Like we all know, I don't want to waste time on the basics of this. You should target a tidal volume of 200 to 300 ml per kg. Smaller the baby, larger minute should be the tidal volume you should target, and all that. So that's all fine. And we have now enough evidence to say as far as conventional ventilation is concerned. But now the question is, in high frequency ventilation, how does it work? Because we all know, yesterday we had the last session was on HFO. So this point was driven home that you actually ventilating the dead space here. The volumes are so too small to penetrate the alveoli. So this is a dead space that you're going to ventilate. And if you're going to ventilate a dead space, then how are you going to? It works. We all know it works. So the concept is slightly different. And to make it more simplified, I'll introduce this concept of differential coefficient of carbon dioxide, DCO2, which can be considered as a surrogate marker for alveolar ventilation during high frequency oscillation. Now, it is, of course, related to tidal volume of high frequency, that is the VTHF, how I will come to. So before that, what is this VTHF? We should know this concept before we know whether it's possible to target this or not. Unless you know your enemy, you can't attack, isn't it? Tidal volume, or in high frequency, the VTHF is actually the volume that is generated when the piston moves in and out. So this is never more than the dead space ventilation. And it's actually generated, all of us know, by the variations of pressure, the delta P around the mean alveolar pressure. But this has a phenomenal effect in eliminating CO2. So this is a VTHF. Now, we also know the basic principle, which I am just repeating to emphasize my concept, that tidal volume is actually determining your CO2 elimination, the stroke volume, or DCO2, whatever I was mentioning previously. I'll come to that. So if you want to increase the ventilation, either you need to increase the delta P or the amplitude, or you have to reduce the frequency. This is how you do in high frequency ventilation. So if you want to, when you increase the delta P, you increase the longitudinal area under the curve, and when you reduce the frequency, you increase the horizontal area under the curve of stroke volume. That's how you eliminate more and more CO2. So fundamentally, we know that when you increase the amplitude or reduce the frequency, tidal volume increases. And then, of course, there is a third parameter which we don't usually play around. That is the inspiratory time. In our good old sensor medics, it was 1:2 what we use. But in the newer machines, I would say refined machines with less power, probably 1:1 is what works. So, but if you change the inspiratory time from 1:2 to 1:1, the tidal volume is going to change. So these are the parameters that you can control. There is no problem with that. So you can always control your tidal volume even if you don't target. But the problem is that tidal volume in high frequency will vary with the ET tube size. You have no control of the type of the tubing that you use, the compliance of the tubing, the performance of the ventilator. You have the King, the Rolls Royce, the sensor medics. It will work so sternly. Whereas you have the finer machines, other machines which may not work that very well. So they are, so the performance of machine is also going to affect your tidal volume. And the last thing that you really want to have as a constant is the one that you are actually treating, the lung condition. So all of these are going to affect your tidal volume. And the fluctuation of tidal volume will lead to unexpected variation of CO2. It will go up and down. So we want to keep it in the normal range. So we try to overdo, and you end up with hyperventilation, CO2 washout, and that is the downside of HFO. Every study has, if you just remember the previous century studies, Hfov study, Hfov study, French multi-central HFO trial, all these have shown that HFO babies develop more number of babies in the HFO group develop IVH, because you try to play around with CO2 and no control. This has been substantiated in the newer studies as well by the Okurama group, the Kaiser et al. Group, and all that. So CO2 fluctuation is probably, to me, that is the only downside of HFO. Pneumothorax we don't get anymore because we use gentle high frequency now. So the concept of recruitment, de-recruitment, re-recruitment will make sure that baby doesn't develop pneumo in HFO. But then CO2 you cannot play around until you target tidal volume. We need stable tidal volume if we need to control or stabilize the CO2. So this is your problem. So you know your problem. So now let's see, how do you do it? If you need to know that, probably what you should also know is that what is the target you want? What is your optimal tidal volume in high frequency? We all know in conventional ventilation, your target for a term baby would be something like 4.5 to 4 ml per kg, and in a extreme preterm baby, it will be like 5 to 6 or something. And then as the gestation age increase, the targeted tidal volume will reduce. This is basic physiology, because we all know smaller babies, the lower gestational babies have larger dead space. You need to cater for that. So it's very perfect. 4 to 6 ml per kg, you are somewhere in the target in conventional. But do you have any idea of what is the tidal volume that you use in high frequency? This is the problem. So I would bring your attention to some studies which are done long back, and these are given us the answers. One of the first is in the 1996, where we established with reasonable accuracy that the dead space in a healthy awake neonate is something like 2.2 ml per kg. And you should not ventilate the alveoli in HFO. You will land up with severe problems. So HFO is always about dead space ventilation. And somebody had tried to measure in 1998, Dimitri et al., they tried to measure the delivered tidal volume when babies were reasonably stable on high frequency. In Sensormedics, they found it was somewhere around 2.2 ml per kg. In SLE, they found slightly higher. I told you it's a less powerful machine as compared to Sensormedics, so 2.6. But this was before the concept of gentle ventilation. So gentle ventilation has come in conventional ventilation. Now we have in high frequency as well. So these values probably may be on the higher side. Now, there is these are the studies, what you see on the right side are the studies of the 21st century. So somebody had looked at the tidal volumes of babies when they were in the normocapnic range on HFO. And then this is the value you have, something like 1.67 ml per kg. And then this is for a term baby, and for a preterm baby, it's slightly higher, 1.74. The range, if you look at, there are many studies, these three studies, I hope you can see, these are studies probably which will really give us a lot of insight into that. So I just summarized everything. When you ventilate a baby with high frequency, the targeted tidal volume, to summarize, should be somewhere between 1.5 and 2.5 ml per kg to maintain your PCO2 in the normal range. That's a large range. I'll tell you how to bring it down. And of course, like in conventional ventilation, in high frequency also, you would require larger VTHF in smaller babies and lower gestational age babies. Now, this having cleared the concept, let us see how does Hfov-VG work. Or Hfov-VG is actually the brand name of the ventilator that I use, that I am using VN500, that says HFO plus VG, the Drager terminology, all-in guarantee. SLE 6000 uses different. So basically it is all targeting tidal volume. So targeting tidal volume, basically, the concepts are similar actually. You set a target tidal volume like in conventional ventilation. Then what you do is, instead of, when you do in conventional ventilation, what do? You set a pip max. Here you set a amplitude max. And microprocessor will adjust the amplitude to maintain that tidal volume. But you should remember, there is a difference here. The machine does not calculate, because each breath is of small duration. So machine doesn't calculate like that. What it does is, it will calculate based on few seconds, 3 seconds of the tidal volume, it will average. So that is how it will calculate, and the microprocessor in the next 3 seconds will adjust. So there is a latent period. You should remember this. It will come handy when you actually put a baby on Hfov-VG. And of course, the change in when you change do not touch the frequency. If you change the frequency, the equations will reverse depending on if you have reached tidal volume or not. I'll come to this. But the summary is that actually you will have lesser episodes of hyper and hyperventilation. So you'll be able to wean the baby fast. So before we proceed, let me clarify the gold standard of high frequency ventilation measurement, that is DCO2. So DCO2 is actually a product of VTHF square and frequency. So this all of us know. So when DCO2 is higher, which actually means that more CO2 is being washed out, and when DCO2 is lower, it means that CO2 retention may be taking place. Now, the problem I told you that in HFO is that CO2 values fluctuate. So that actually, so you see it in the machine as DCO2 fluctuation. You don't need PaCO2. So you don't need blood gas if you can really understand the concept of DCO2. It will fluctuate when the baby moves. Depending on what is the position, what is the type of lung, whether baby breathes. When baby breathes spontaneously, definitely there will be variation. When there are secretions, you know that DCO2 will fall. If you do suction, DCO2 will increase. Then when the healthcare provider handles, again it will change. So this is the problem that you find. If you set the frequency and amplitude same, then on a particular frequency, the DCO2 values change. But if you put the baby on a targeted tidal volume, you find that DCO2 remains constant and the amplitude will fluctuate. If there is more secretion in the lung, amplitude requirement goes up. When you do the secretion, amplitude requirement comes down. But let me tell you, this is not as simple as what I said. I just simplified the concept for you to understand. It doesn't work like that. Knowing DCO2 probably cannot predict in a linear fashion the PaCO2 of the baby. DCO2 values actually are dependent on various other parameters also. The weight of the baby, pathophysiology, ventilator settings. So how do you make sense of it? One way you look at it, if you are not using volume guarantee, still you can use DCO2. How you look at it? You look at the trend for that baby and try to correlate with the PaCO2 values of the baby. The correlation factor in each baby will be different. You need to understand this. So somebody had tried to simplify this by giving a weighted correction. They actually divided the DaCO2 by the square root of weight correction. And this was slightly encouraging results. A new study published 2.5 years ago, and they found that the difference narrowed out. So which means that if you have a target, because you always want a target, isn't it? If your DaCO2 the correlation factor was somewhere between was more than 50, it was the chance of baby developing hypercapnia was something like 17.5, and if it was more than 60, chance was less than 10. So somewhere around 60 is the value you are playing around, or I would say to start with 60 to 80 is the value that I use when I start. A weighted correction of DCO2, authors conclude in this paper. Mind you, this is only one paper. There are only 2-3 papers like this, which promise that this is more informative than looking at the DCO2 value alone. You correct the weight. This is in correlation with some of the older studies which try to look at the tidal volume also. Like the study I mentioned, Dimitri et al. 19. This study is being quoted in all these, if you will remember. So that is, so this is the feasibility. Now I'll tell you how to do it. Before that, let's see what is the evidence. Will targeting tidal volume improve the outcome? The first of these studies, feasibility studies, was published in 2013 by Sanchez Luna group. And this is the group that has published 3 animal studies and then 1 human study as well, but not in the same field, but similar field. So always the study model had the maximum similarity to human newborn. So the newborn piglet model was used in all these studies, and they found that when they used the ventilator used was the VN500 again. So it was when you use Hfov-VG, you found that the PSO2 and DCO2 were stable. I just enumerated the 6 worth studies which you can really look at to understand this concept. Of this, only as of now there are only 4 human studies which can tell you this concept and 2 animal studies. And of all these, only 2 papers can really tell you the concept because it's such a new concept. And they are also, if you look at the evidence and then try to filter it out, you are not on very strong grounds, because one is an RCT of a small number published in 2015 in neonatology, and the other one was a Japanese study, a pilot study. They looked at babies who get stuck, extreme preterm babies who get stuck on HFO for some time. After 1 week, they recruited. Martin Kessler was also part of this, even though it's a Japanese study. So the conclusion from these studies is the RCT, the only RCT available on the topic, and without doubt we were able to say that the fluctuation of tidal volume and the incidence of PCO2 levels can be correlated, which means that if you maintain a tidal volume, it is feasible to maintain a VTHF in the stable range, and it can eliminate your PCO2 differences to minimum. The Martin Kessler group, or rather the Enomoto group, they did actually, the number was very less actually, less than 24 weeks babies. The pilot study, what they published, the other paper is not yet published. So again, they found even benefit not only in PCO2 and DaCO2, they found benefit in saturation CO2 clearance as well. So this is where the world stands as far as evidence is concerned. We had a humble study which we initiated. It's not at over. So far, we have recruited 11 preterms in this, and then I just try to, for this talk, I just try to summarize that. The red stands for the without VG, and the green stands for with VG, and the standard deviation. So all the values, none of them are, but as of now, statistically significant, but all the values we see, the benefit is more as far as heart rate, blood pressure, the saturation, SpO2, PaCO2, all these are concerned. We found that, probably, so there may be some promise in this. So this is all as far as evidence is concerned. Now let me come to the last part, that is how to use such a Hfov-VG before we take questions. So this is based on the non-evidence based practical approach adapted from Jane Pillow's recommendations and then subsequent this thing. So this is, if you ask me evidence, nobody can give you evidence because I told you the number of studies in this field are very, very less. So how do you start? You set, like in HFO without VG, you set your MAP as usual. So when you set your MAP as usual, remember, recruit, de-recruit, re-recruit. Otherwise, you will land up with air leaks. So if you do this maneuver, you will never land up with air leaks. So de-recruit and re-recruit and maintain the minimum MAP required to maintain the saturation. And after that, you usually, if you don't know the values, you can keep a very high amplitude. It's like a limit. Ideally, it should be 20% more than the actual amplitude requirement, which if you don't know at the initially, then you can scale it down. And usually I start with 2 ml per kg for a term baby, and then maybe higher values, 2.4 or 2.5 ml per kg for a extreme preterm baby. This is just a range of values that I use, and this has been I just followed some of the protocols that will be in use at this point of time. So you can set your some tidal volume that will give you decent PCO2, somewhere between 7.28 and 7.3. not more than 7.3 and not less than 7.28. To get this, whatever is the tidal volume required, you use that, and amplitude will automatically get adjusted based on last few cycles, and then as the lung compliance improves, you'll find the amplitude will come down. Initially, it might have been 24. It will come to 22, 21, 18. Like that, it will come down. And what the good thing is, you will never get, or rather the chances of getting hypocarbia is less, because always the amplitude comes down and adjusts. There is a catch in this. You need to have your correct frequency. Remember some basic physiology. The resonating frequency of a term lung is somewhere around 10. I'm quoting 1997 study. So it's an old study. But then that's all what we have as far as hard evidence is concerned. And for a preterm baby, the resonating frequency is somewhere between 12 to 15 or 12 to 18, depending on the gestational age. Lower the gestational age, higher the resonating frequency. And until you get your right frequency, you will have to keep on changing your frequency. If you get your right one, then you don't change your frequency. Because changing frequency, the concept does not become gentle. It becomes a coarse ventilation again. Though after you reach this, now once you set your tidal volume to 2.5, amplitude max, you have kept a value. The first thing that you look at is, with this amplitude, am I reaching my tidal volume? If you are not reaching, then probably you cannot go more than 60 and all that amplitude, isn't it? So you would need to adjust your frequency to get your tidal volume right. Always aim for a higher frequency with spare amplitude available. This is based on some animal studies which saw that the chance of ventilation-induced lung injury are much less in this. And once you have said this, you can do one gas. Then no need to do gas. Maybe once a day gas is also good enough if you are a master in this. So one gas to tell you where you stand. Further adjustments are actually based on when you wean. Suppose you have reached the target, and then slowly there is a CO2 is slightly building up. You may need to increase. You are not using a correct frequency, because nobody told us babies don't read textbook, and they don't know that they need to have 2 or 2.5, whatever you have set. So if they are not reaching the target, you adjust your frequency. Usually never you need to go up more than 2.5, 2.6. So you should know your target tidal volume. Once you read that, don't touch that. Then baby will auto-wean. Once the auto-weaning happens, then you have the ventilation part is taken care of. Then when the oxygenation taken care of, extubate. No need to go to conventional ventilation. So your ideal endpoint, I'm just talking to about the most ideal scenario. We know so many other things also go wrong. We can discuss that in the discussion if anybody is interested. So the ideal endpoint is static DCO2, which actually ventilator will adjust by changing the amplitude or delta P. Now, if the ventilator, like in conventional volume targeting, if tidal volume is not reached, there will be an alarm. So you need to adjust. Always remember, except in sensor medics, all machines work best with a power of 1:1 ratio. And of course, suppose you have a DCO2 trend which is remaining, and suddenly it has fallen and baby desaturating. You know that it is time to do suction. You don't need to look at anything else. Now, I want you to remember one more point before I'll try to wind up or something. So this is regarding the equation between frequency and CO2. In conventional, we know when you increase the frequency or the rate, what will happen? More and more CO2 gets washed out. In high frequency, when you increase the frequency, less CO2 gets washed out because of the area under the curve comes down, as I explained. But this is without volume targeting. Now, once you have reached your tidal volume, the equation changes from VTHF square to frequency DCO2 to a constant square into frequency. So in this case, if you touch the frequency, the reverse will happen. Like conventional ventilation, if you increase the frequency, more CO2 will get washed out after you reach your tidal volume. Just remember this point. And if you reduce, less CO2 will get washed out. So do not touch your frequency. That is the important thing you should remember. And of course, DCO2 can be used as a measure of alveolar ventilation. I am not totally evidence-backed when I say this. I have been doing this for the last 4 years, and reasonably I am confident to start with something like 60 or to 80 ml square per second per kg square, and then depending on that you can come down or up and down. And auto weaning is what I told you. If you give enough spare amplitude, and once you reach the minimum amplitude, and baby's DCO2 is stable, you have to look at your oxygenation. That is the main problem. So once you can just, the only button you need to wean in such scenario would be your MAP. As the baby improves, of course, if you have reached FiO2, also air or something like that, MAP, once you reach the minimum, whatever is your protocol, you can consider extubation. There is no need to go to conventional ventilation if you use this mode. And this is probably the documentation part is exactly same. Like I'm sure it must have been discussed yesterday also. When you ventilate without VG, you need to record these. Ask your nurses to record all these parameters: FiO2, MAP, delta P, that is achieved, tidal volume, DCO2, and these values are anyway important. So even without actually having VG button, you can target tidal volume if you can understand this concept. I stopped here. I can ready to take questions anytime. Thank you.
Yeah, thank you very much, sir. We will complete another session. After that, we'll take up discussion. Now I request Dr. Dinakara sir to start the session. Dr. Dinakara sir. Singh, can you make Dr. Dinakara sir
slide share?
Co-host.
Slide share.
Yes, sir. Yes, sir.
Slide share, madam.
You can start sharing this slide. Yeah, start the presentation, sir.
Yeah, good evening, everybody, respected sir and teachers. I think so my talk will be very, very little different, because whatever we read till now, I am going to differ so many things. So is it audible, Prashant?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So what I want to tell you is non-invasive, without intubating the baby, high frequency ventilation, how better we can use it on the neonate. Number one. So number thing, what I am going to tell you is, why do we want to switch over from CMV mode to the better modes? Everybody knows, if I'll put this, sir, we know it. What is bronchodysplasia, ventilator associated pneumonia, ventilator associated lung injury, air leak, atlectrauma, biotrauma, volutrauma, oxidative stress, iatrogenic trauma. There are multiple things. Everybody knows what is this. Even if I'll intubate, sometimes we might not able to, baby might not able to clear its throat, trachea. So sister have to do the tracheal section. So long term, suppose if you will intubate the baby for a long time for something else, subglottic stenosis can occur. If anybody face this problem, they only know why I intubated baby long. Previously, we used to see many subglottic stenosis. After non-invasive, hardly we do see now. Okay. Even sometimes when conventional ventilator will fail, definitely we do go for a better ventilation mode in invasive. What is that? Everybody knows it is HFO or HFV, high frequency ventilation. I didn't tell HFOV. I didn't tell high frequency flow interrupter. I didn't tell high frequency jet ventilator. I didn't tell high frequency percussive ventilator. So that means we will go for a high frequency ventilator. Okay, suppose, no, I don't want to go for a high frequency ventilator, invasive mode. So what we will do, suppose after the post extubation, then after the, suppose I don't want to ventilate the baby, is there any other mode? Suppose CPAP we used, NIV we used. So is there any mode? We thought. So that time after NIV is failed, definitely we search whether non-invasive any other mode is there or not. That is how we have come to conclusion and made an algorithmic approach of non-invasive ventilators. So I think so Dr. Srinivas and Dr. Shiv Shankar explained very nicely in their talk. In fact, I am really fan of both of those people. Beautifully they explain. So what is this? Non-invasive ventilator support. First thing, many people know CPAP, know what is variable CPAP. What is that? Please follow this. It is really, really very interesting. See, constant air pressure means continuously we are throwing the flow. So through the nasal cannula, what is low flow nasal cannula? Means less than 2 liter we are giving oxygen. High flow nasal cannula, we are giving more than 2 liter oxygen or blended, whatever the supplemental things. Next, other than that, same constant flow, is there anything? Everybody knows CPAP. So once again, do you think, sir, CPAP mein kya hai? So constant flow CPAP. What is that? Other than constant flow CPAP, conventional CPAP. What do you mean by, sir, conventional CPAP? That means CPAP in the ventilator. So other than that, nowadays what we are using is bubble CPAP, because conventional CPAP mode is outdated. Okay, we are going to discuss all those things very quickly. Then variable flow CPAP. Variable means during the inspiration, the flow what you have set, it will be flowing to the baby's nose, to the pharynx, larynx. During the expiration, it varies, like Conan-Doyle effect. It's a big English word, but people knows it. What is Conan-Doyle effect? Sir, why then variable flow CPAP is gone? See, there is one article, why good things sometimes will vanish from neonatal things or neonatal equipments, good equipments, why it vanishes. There is a good article is there. Just go through this. Really variable flow compared to the conventional flow, or this it was good. But after bubble CPAP, since bubble CPAP is very cheap, number one, effective, number two, better than variable flow CPAP, user friendly and less expensive. That is the reason bubble CPAP in the constant flow still we do use. Because variable flow CPAP, where we will get, sir? Variable flow CPAP, that day I showed you in my, what is that, after the discussion or during the discussion, I showed you in the my mobile single limb CPAP, that is nothing but an variable flow CPAP. It is available in Fabiana machine, otherwise SLE, Leone. There are so many other machines. They do have variable flow CPAP. It is a single limb CPAP. Come to our topic now. Variable airway pressure. What do you mean by variable airway pressure? Here constant, here variable. Simple thing. Here there are double P. Please observe. PIP is also available. PE is also available. So PIP and PEEP both are available. That is the reason variable airway pressure. So what do you mean by yes, sir? Yes means it is synchronized. because IPPV is not synchronized. SIPPV is synchronized during the inspiration. So then there is one more company person has termed called BiPAP. That is the same like SIPPV. This is also synchronized. At the same time, some company person has told NIPPV dusra naam. What is the other name? That is called DOPAP. So NIPPV, DOPAP is the same word, not synchronized. SIPPV, BiPAP is the same word. That is also same thing. Okay, both are synchronized. If all these things are failed in non-invasive support, only thing is today's my topic, non-invasive HFV, high frequency flow. It's a beautiful slide. Really, if you are a teacher, you can just memorize it, or if you are a fellow, please memorize it. It will be very easy. Next, sir, okay, you told everything fails. Then why to go for non-invasive HFOV? Just now I told CPAP. Sir, definitely CPAP will splint up the upper airways, stabilizes the lung by splinting, increases the functional residual capacity, decreases the work of breathing. It's a beautiful machine, cheap, easy, sister friendly. Then suppose sometimes if the lung problem is very severe, baby is not able to breathe, or the effort of breath or breathing is inadequate, because of that PCO2 is raised, respiratory acidosis is setting in. Do you think still you want to continue with the CPAP? Yeah, if you continue maximum, you know what is CPAP failure criteria and indications. More than 60% oxygenation, pressure is more than 8 or 9, some books are telling. So if it is not able to maintain the SpO2 or PaO2, whatever the range you necessary, more than 90%, more than 60%, then we will switch over to this. Beautiful. I told you that two great speakers have spoken this, NIPPV, SIPPV. And I don't want to touch about the NAVA, neuronally adjusted ventilator assist. It's a beautiful machine. I think so. Whoever attended cardiopulmonary venticon, that time we called the person who have done and written many articles and a pioneer. You people know it. We called him. He has taken one ventilator workshop only on NAVA. It is all EDI. It is also very easy. There is a proverb when I was MBBS student, and after finished my MBBS, I was working in one ex-hospital. Some doctor told me, till you learn, it is a very difficult thing. Once you learn, it is very easy thing. So you can play. That's what he was telling. NAVA was I was thinking NAVA and HFOV is, my brain won't get it. See, it's all how you think. Suppose all these things are having its own problems or financial constraint, then we do go for high frequency ventilation with the gentleness of non-invasive mode. This is my topic today. Okay, now yeah. So I think so. You people have, once again, how to play? How to play more. Next slide. Yeah. Next slide. Oh. I think so. You people have just now watched the video. Simple thing. You people might be thinking, what is this nonsense? Please, my dear friends, what we do, what we see regularly in our lifestyle, the same thing our brain doesn't know. See, I told my postgraduate to put the water into the water tank. What we do, drink every day. So I told him to put. I saw when the water was flowing, the bottle was sucking the air, the reverse of bubble CPAP. Because of that, when the bubble was bubbling out, it is started, because of that bubble, it is started producing the sound. Because of that sound, complete that tank was moving, oscillating. The same thing we do see in the bubble CPAP. And I showed you also, when bubble was bubbling, there was so much oscillations was there. On that oscillations, the people thought it will transmit to the stochoic resonance. That means if you will give that something sound, there will be always background noise will be there. Because of that background noise, anything it will oscillate or vibrate. So they have incorporated and seen it, because when the patient was breathing out during the expiration, whatever the thing was going, you are giving the bias flow of 5 liter, 4 liter or 3 liter or minimal bubbling needing. Whenever the baby exhaling, it should go to the pressure. So a bubble generator, whenever that bubble generator bubbles, it will make a noise. That noise is the same thing what I am showing you in the picture. See, slow bubbling with a 3 liter, the same thing 6 liter. How much stochastic resonance is there? Resonance means noise. That much, how much it can oscillate? Yeah, that one from the bubble CPAP, they have taken it, because bubble CPAP will do the same work. That is the reason the wiggling or bubbling, really, is it helpful in CPAP? Yes, it helps, because it acts like an amplitude in the Hfov. We know that what is amplitude, but that amplitude is depending on, once again, flow, or each baby might have expirational volume low or sometimes more, or if you will put the flow more, so you might develop a more flow, so more amplitude. And the frequency is multi-frequency and low frequency. That is the reason what they did, they have incorporated. At the same time, it will develop the mean airway pressure, see. But do you think whatever you set exactly, do you think it will deliver? It might not in the CPAP. At the same time, even Hfov, non-invasive Hfov, it might not deliver, but it will achieve more better than CPAP. Number one, that is the how idea is evolved. Bubble CPAP, that is the reason bubble CPAP is nothing but an non-invasive Hfov. The people do tell. Now, how it works, same thing I am telling you. Already, because of the bias flow, we have given the mean airway pressure. Because of the flow, what it is generating oscillations, we are imposing the more tidal volume on the spontaneous breath. All those things. Please, my dear friends, see this. It's not flowing. Okay. See, what I want to keep is, one is membrane. This is how the bubble CPAP, what is that? Non-invasive Hfov, it's a membrane. This is a piston. So this is a valve type. Please go through. Please, this is very important slide. Non-invasive Hfov provided by different ventilators have an oscillating piston. You can see, I don't know why GIF is not working. Piston, membrane, what you are seeing here is a membrane. What you are seeing is a piston. This is the fan type. Please see this. Somewhere it is gone. Yeah. Some other devices produce oscillations with the flow interrupter. What do you mean by flow interrupter? Like exact what we are using is SLE 6000 is a flow interrupter. But do you think, can I use non-invasive Hfov? We are using, I am using, it is giving a beautiful results, but it's not a true oscillation. It's a negative sucking pressure, negative valve resistant pressure. That is called SLE 6000. Okay, but if you take a VN500 or Fabiana, it's a true oscillator membrane, or VDR4 or Bertan or even Leone or all are a true oscillators. But this one is a flow interrupter. But all the machines will do a what it should do. And another is a fan and valve mechanism. Okay, fan and even oscillator is, anybody is using Medin CNO, that is also, it is purely non-invasive HFOV, and other non-invasive modes are there, that is also flow interrupter. Come to the HF, high frequency jet ventilation. Sir, one thing you people should remember, all the ventilator is active in inspiration, active in expiration. Because of active, it sucks the air outside and it pushes the air inside. But high frequency jet ventilation is passive in expiration, but it delivers little more, very low tidal volume, and even hertz are very less. That is the reason the frequency is less compared to the normal high frequency ventilator. Number one, percussive ventilator is a lower ventilator, means the frequency is less than 200, 100. I mean, it's 6, 8 like that. But it is a very good ventilator for transport, HFOV. This is too much. Next we will go. Okay, I want you people to know, sir, you told me about which is true oscillator, which is true flow interrupters. The physiology of HFOV. Why? Physiology means I want to tell one word, whether CPAP is better, NIPPV is better, or HFOV is better. That means what I am talking is physiology. Please, this is very important slide. Non-invasive HFOV does not cause laryngeal closure and partially prevents any abdominal distension. How far it is true, I am going to tell you. Already I have put a picture here. Please, if you are following my cursor, see this. Okay. And the second one is, it is a synergistic effect. What do you mean by that? I am going to tell you. Non-invasive HFOV does not induce phasic. This word is very important. Phasic inspiratory glottal constriction, and conversely did not decrease inspiratory glottal dilatation. That means these two words will make my slide. I am for the non-invasive HFOV. That means when you are giving the CPAP, if you will increase the CPAP 5 liter or 6 liter flow, for a small baby, what happens if somebody blows air into your ears or eyes? What will happen? You will go away, means you will close your eyes. Like that, if you will give the more flow to the larynx and pharynx, that laryngeal muscles will come near, means closes the trachea. Once it closes the trachea, what happens? Air flow to the trachea and lungs will come down. Number one. Suppose if you are giving NIPPV and if you are giving PIP pressure, 18 pressure, 20 pressure, 24 pressure, that time bulk volume will go to the larynx and pharynx. That time protective mechanism will come into the play. If it is a small baby, if you are giving 20, that might be more flow to the baby. Protective mechanism, that time what happens? Baby won't get more flow to the trachea because of thyrocricoid, cricoarytenoid muscles, which is very important to control protective mechanism of the trachea, means thoracic inlet. Because of that, more air will go toward the abdomen. That is the reason CPAP tummy will develop. This is number one. Please understand now. And CO2 washout. Definitely CO2 washout. I told you it is better than CPAP because both inspiration and expiration is active. Number one. That is the reason it sucks away the air. Then definitely CPAP I told you, not variable CPAP. CPAP, during the inspiration also same pressure will be thirsting on the larynx and pharynx. During the expiration too. And even NIPPV, it is not synchronized. It is thirsting the pressure. That time what happens? Inadvertent PEP development chances is there. At the same time, Hfov, since it is supraphysiological rate, it doesn't need any synchronization. That is the beauty. That is the beauty. One is, I told you, laryngeal. Another is CO2 wash. This one is it supraphysiological one. It doesn't need. And the same thing will come. Please, I request everybody. One thing you should remember, when you are putting non-invasive Hfov, you should put the what is it, nasal prongs bigger than the CPAP diameter, CPAP nasal prongs. At least CPAP, you will cover 2/3, 1/3 you will open. Nasal Hfov, you will at least cover half. But here it should be tightly means it's not bulge, snugly, comfortably fit nasal this thing. And better patient ventilator interaction. See, so many things are there. That is the reason, compared to CPAP, compared to NIPPV, definitely non-invasive Hfov is better. That's what I just now showed you. Thyroaretinoid, cricoaretinoid. Please go through one. I'll give a pass. Normal function, I gave a pause. It's beauty. So whatever I told you, this is the things is happened. See, NAVA definitely better. That is the reason NAVA is better than NIPPV with the synchronized. Then see about this thing. It is like a normal physiology. Okay, now come to the one more beauty. Why it is better? Non-invasive Hfov decrease GER, gastroesophageal reflux disorder. I'm not talking disorder, it's a transient. GER, how? Please, this is also a really, I love these 2 slides. Please, if you are not concentrating, at least concentrate now, it is better. Because if you have a 800, 700, 600 grammer baby, sometimes we do repeatedly intubate or put on something because of the gas GER. After giving the feeding, baby will have a desaturation, microaspiration, then lung will become bad, then intubation, then BPD, then so many headaches. So unnecessary money for the parents as well as you. If it stays long, nosocomial infection, hospital acquired infection, at last death. Otherwise very bad neuronal program. So if you will use this, how you can prevent all these things, dear friends? See, number 1, remember everybody, you are putting to the nose nasal prongs, you have started the Hfov, remember like that. What happens? Because of the coordination with the laryngeal muscles, I told you, thyroaretinoid, cricoaretinoid muscles, the air is comfortably flowing to the lungs. Yes. At the same time, what happens? Lung will have a more stretch. If lung is stretching, diaphragm will be pushed down and more comfortably placed. If diaphragm pushes down, length of the esophagus stretches. Please remember what I want to tell you, it stretches. The length of esophagus is stretched. Imagine the gastroesophageal should come to this far. So it stretches. Once it stretches, at the same time, lower esophageal sphincter will become more constriction. Number 1. Okay. Then once it constricts, what happens? Relaxation time and depth of relaxation. Relaxation time and depth of relaxation will increase. Next, I told you longitudinal contraction of esophagus. Next, because of the diaphragm, I told you, because of all these things, one is length is increased, another is the contraction is increased, contraction time is increased. Okay, relaxation time is decreased. At the same time, now what happens? We are giving the pressure that will act like a preload to the esophagus. To the esophagus, it will act like a preload. So whatever the flow is, it's coming here, pressure is there. So gastroesophageal reflux disorder starts coming down. Okay, number one. Because of the synchronous, so there won't be much problem. Then all these things will decrease us compared to CPAP, compared to NIPPV. There also same mechanism will happen, but here comparison is, this is far better. Okay, next. Okay, doctor, you told me how it is better in GERD. Then you told me how it is better in, what is this? How it is better in biophysiological wise, you told me, doctor. I am very happy, doctor. Now, is there any other better thing is there? Definitely yes. Definitely yes. Because there are two things, nitric oxide synthase. This is little theory, but you have to take me, please. Okay. Nitric oxide synthase, what happens? It comes down. Then inflammation will come down. Everything is decreasing. Definitely there is something, surfactant B protein will increase. B protein will increase. You know what is B protein function. So more production of phosphatidylcholine, all those things, glycerin. And D and C, immune, you know that. It's more better. Come to the inflammation that I am going to tell you. Inflammation. This is once again a very nice thing. I found it. Very nice thing. See, I don't know what is parathyroid hormone, PPPA. I don't know what is it, but what the book will tell is, because of these, two things will happen. One is mesenchymal proliferation. At the same time, lung and alveolar togetherness, interstitial integrity, inflammation, and you know, all those things will reduce. Surfactant production will be better. Angiogenic pathway increases. You know what you mean by alveolar capillary dysplasia. That means alveoli is one side, capillary is here. Otherwise, vice versa. If both are same side, but it is very apart, so oxygen and CO2 cannot take place, means cannot get a exchange. So that won't occur because two reasons. Number one is all the inflammatory cascade will come down. So lung development is better. Since lung is developed, baby is developing very happily. Somatic growth is there. Neuronal growth is also better. So since neuronal growth is better with the gentleness of non-invasive HFOV, definitely outcome is better. Please see this. I don't want to tell you. I have taken from one article. Thank you for that article. But see, somebody ventilated with conventional ventilator. You people can see, if you're seeing my cursor, I am very happy. See, terminal bronchiole, respiratory bronchiole. See, wide. It is like there is called a bronchiectasis. We heard that in the pediatric or in the adult. It is like a bronchiectasis picture. Means PPD picture is there. See, there is no alveolus. See here. Terminal bronchiole, respiratory bronchiole. There are so many alveoli. I am very happy. Okay. This is the one I want to tell you. This is a beauty slide. Beauty slide. Once again, BPD. If anybody wants to know the simplest definition of BPD, I want to tell you, this is my simplest definition of BPD. Please, what do you mean by bronchopulmonary dysplasia or chronic lung disease? The word you take a chronic. Lung, incomplete resolution. What do you mean by incomplete resolution? That means inflammation, infection is not completely resolved, or air leak, what is there in PIE, is not resolved. So inflammation, infection, air leak or some exudate is completely not resolved. Because of that, repair is incomplete. So simple word, yes or no? Because of that, even capillary alveolar dysplasia or PPHN or interstitial problem, whatever, so many problems are there. Okay, infants. Sir, people are asking. This is a beautiful, once again, slide. What happens is infants may have a mixed restrictive whereas obstructive, both are there in this. So hypoxia is also there, hypercarbia is also. Air trapping will be there. That is the reason we do use in high frequency ventilator, low frequency, because need a more volume. Then little more pressure, that is delta P for the more volume, because restrictive as well as obstructive airway disease both are there. We have to take care of that. That I'm going to tell you how it is. Please go through, because if you don't understand this word, you won't understand the next slide. Lung is having obstructive airway disease, lung is having restrictive airway disease. That is the reason I want more volume to go. Okay, that is the reason I'm decreasing the frequency, increasing the delta P. Optimal MAP I'm going to keep. See the word I used, very cunningly I'm using the word optimally. Okay, next, lung mechanics is a different. All, see, beautiful lung mechanics may be different, patients may have a different, all those things. Try to use for the HFOV bigger nasal prong. That is most important. Okay, then the parameters are different, all those things. PA, I told you how it is. Delta P, please increase, I told you. Visible, that I'm going to tell you in the next slide. Sir, I heard that when in HFOV, when you put chest should wiggle. Sir, chest should wiggle. Even in non-invasive HFOV, chest should wiggle, sir. That I will show you live today. Live today, there are 2 babies with us, non-invasive HFOV, since many days. Okay, I'll show you. No need to even just wiggle. At least larynx, throat, chin, if it is wiggling, that much is better. If too much wiggling, I don't know, no article is telling IVH will develop or not, but I don't know. Really, in one study, there are 3 IVHs have developed. Whether it is previous or next, that is incomplete study. But I do keep, because I am using non-invasive HFOV since 5 years. So volume guarantee since 4 years I am using. But volume guarantee HFOV, both are a beautiful machines and is easy friendly. You know, delta P and frequency. Delta P, whatever you set the delta P, it will deliver. And one more thing, if you will deliver the delta P, what is OPR? We people should know oscillatory pressure ratio. You have kept example 40 delta P, means amplitude. Do you think all the things will go to the larynx, pharynx and trachea and inside? No, you know that wherever it obstructs, it will attenuate. So you need not worry for that. So use it. So IT time, please, I am requesting everybody, IT time 1:1 in non-invasive HFOV. Even NIPPV 1:1, even SIPPV 1:1, BiPAP 1:1, DOPAP 1:1, even non-invasive HFOV IT 1:1. In invasive, it's up to you, 1:1, 1:2, it's up to you. Okay, interface, I told you we can use nasal prongs, we can use nasal mask. Okay, let me tell you, finish it here only. And do you think if somebody asks me, I use bigger bore nasal prongs, and it should be little stiffer. It should not be very elastic, because once the amplitude comes, once it hits the pressure, it should not attenuate. So what I want is little stiffer, but it should not damage the baby's nose. Number 1, it should be straight, whiteboard, anatomical position. And sir, can I use mask? Yes, you can use, but when you use the mask, it is little difficult, because you know, we called one person Dr. Mukherjee. You know that Dr. Mukherjee, he is the one, he has written many articles from Canada. He has come to India. He has delivered one lecture in cardiopulmonary ventricle. And in fact, he has taken one complete session of non-invasive HFOV, one workshop he has taken. So even in his studies and things, if you use the nasal prongs, stiff wide bore nasal prongs, better delivery of amplitude will be there. Number one. What about nasal mask? You can use nasal mask, but amplitude attenuation chances are there. Some people who have come from abroad like UK or Canada or somewhere Australia, they do intermittently change nasal prong some days, and after 2 days nasal mask. It is their comfort, but it is no strict and hard rules. And I showed you, is there mouth closing is important. Please try to close the mouth. It is also, I told you, better CPAP. That's it. Then all the things I showed you, nasal, all those things, please go through, deoderm with a cushion and this thing. Please use all those things for the baby's protection. Then come to this slide. I'll go to the next one. This is all theory once again. Ventilator specific mechanism, delta P, IE, frequency. There are only 3 things you are going to set, sir. One is frequency, delta P, that is amplitude, IE ratio, and oxygenation. That will determine your tidal volume. Sir, please, everybody here, see this. Just go through this slide. What it is telling is 30% or your delta P is 30. But what happens, your delta P 30, here IE ratio, please see this. Once again, IE ratio I kept 50 and 33. Wherever you kept 1:1, your tidal to deliver volume is more. That's what I am telling. Delta P, if you'll keep more, IE ratio 1:1, you will deliver more tidal volume. As well as, see the frequency. As you decrease the frequency, but outer diameter is, say, the internal diameter, both are 2.8, 2.8. But outer diameter is, this is tight, this is little loose. See the delivery. That is the reason I am telling you, it should be snugly, means is tight. It should be fitting. So when you decrease the frequency, more volume. Once you increase the amplitude, more volume. Once you make the IT 50-50, more volume. Then this is also same thing. See, compared to the NIPPV, how they have done the study, how they have, see, NIPPV, what happens is, pressure is 18/5, IT time, rate, see the CO2 washout is very, very, very minimal compared to the frequencies. So better frequency for non-invasive E is 6 to 8. Remember, 6 to 8. Come down. The same thing. This is also CO2 washout. This is also. Please, I want you people to see this. You have ventilated one baby. First with the NIPPV. Okay. The patient, everybody we showed. This is capillary O2. What I am telling, this is a capillary O2. This is a capillary CO2. Definitely it is very high CO2, you people can see. So O2 is very low. And what about this triangle? Can you people see the triangle? Okay, this triangle, even pH is very low. Just shift it to the non-invasive HFOV. See, oxygenation improved, CO2 washed out, and even pH is improved. That is the reason I told you till now, CPAP, NIPPV, non-invasive HFOV, physiological, biological, whatever logical, it is better. But only thing is expensive machine. But why I took this slide is, many government doctors from North Karnataka and many places, they told, we bought this machine, please teach us. Machine is there, they have to know it. Okay, indications. Even, sir, can I use first? You can use. It is very easy, boss. You should use it. Then can I use rescue? Yeah, you can use HFNC. If it fails directly, you can use. After that, if HFNC failure, they put on CPAP. After that, they put on NIPP. After that also you can use. Think of how long you put it, how long you damage the lungs. Okay. Then see this. This is Mediana from UK, one machine. They gave me for the what is demo, even in that machine. And one more thing, why I showed you this picture is beautiful. Please see this, because I was not knowing how much powerful this machine is. How much powerful this machine is. So I increase the delta P. Because non-invasive HFOV, sometimes if I'll keep how much volume it was giving, I don't know, because I was using first time. So it was giving very high tidal, means more powerful. Then Fabiana, now we know every day we are using. Then SLE 6000 every day. So first, before you buy the machine, you should know what is the power of that machine. How much, if I'll keep 20, how much delta P means 20 amplitude, how much volume it will give. Suppose if it is, so there are so many slides are there. Each machine, if I'll keep the pressure, same the prongs, how much tidal volume. There is a power, means comparison of each machines, the power, amplitude, how much delta, how much volume it will give with the frequencies. Now, I will just, it is only suggested parameters. Even if you are beginner, start this, then you can learn in your own with the babies. It is not a big matter, really. Suppose if the lung is very good, mean airway pressure, definitely when you will extubate, when mean airway pressure is 8. Definitely same thing or 2 more you can do it. Delta P, just double than that you start. Delta P means amplitude, double than the mean airway pressure. Always start double. Sir, should it wiggle? Need not worry, sir. Okay, even sir, you told me chest, you told me cheek should wiggle. If it is not seeing, don't worry, slowly do proper suction, start. Frequency, normal lung, so start with the 10, doesn't matter. Okay, then put NGT into the stomach, better, it will decompress the stomach if their air goes. Number 1. Suppose if the baby is bad, lung is bad, BPD, RPI, some disease is there. Try to increase the pressure, sir. Delta P2 should be increased. Only frequency should be decreased. Because I told you frequency decrease, volume will increase. Delta P increase, volume will increase. Here in the non-homogeneous disease, restrictive as well as constrictive problem is there. So that's one, sir. Then sir, one more thing everybody used to ask me, sir, when should I decrease the frequency in HFOV? When should I decrease? Don't worry. Whenever mean airway pressure and amplitude, mean airway pressure is 12, amplitude you are increased to 24. Suppose if it is touching near to 3 times, 12, 12, 12, 24 plus 12 is 636. If it is coming near the 3 times of the mean airway pressure of the delta P, you are reaching, that time you think of decreasing the frequency in invasive HFOV. Here also same thing, sir. When you are touching the delta P near to the 3 times of the mean, that time you start decreasing the frequency. Very, very easy, dictum and evidence-based thing. Okay, sir. And all those things I have written, how to adjust all those things. See here, there is a baby. After 1 week, X-ray, HFOV, on 19th day, they started. This is the X-ray on 1st week. They kept on on ventilator. Then the 19th day, they started. So now you have to tell me means at least talk in your mind. In 10 days of non-invasive HFOV, they didn't continue the ventilation. Baby became all right. So what mean airway pressure he might have kept, delta P, frequency? Think yourself, sir. Frequency definitely low because I need more volume. Yes or no? Yes. Delta P little more side. Amplitude little more side because restrictive and obstructive. Obstruction should overcome. So more mean airway pressure. That means around 15 to 20 or 18 mean airway pressure, 35 delta P, frequency should be 8. Keep it like that. As lung is improving, you also don't keep the same and forget it. Please don't do that. What you should, if the lung is improving, start increasing the frequency, start decreasing the delta or mean airway pressure, start decreasing the amplitude, because that you should know when to decrease, when to increase. So this is the one thing, combining non-invasive HFOV with NIV. Some machines do have it. Sir, can we use it? Like HFOV with the sigh breath, invasive mode. This is the same thing. Yeah, you can use it if there is a homogeneous lung disease is there, you can use. Not in PIE very strictly. Not in PIE or cystic diseases you can use. Then this is all some things people do ask me, what is the least gestational age they have used? 23 weeks, studies will tell. I don't know, because I never come across so small baby. Then first article published in 1998, how long they have studied? Up to 21 days. But with me, one baby is 700 grammer baby, now became 1.2, 1.1 kilo. I am using now more than 1 month. I used only non-invasive HFOV for that baby. Baby is doing well. And what is the outcome of non-invasive HFOV? There is a studies. So many people have done non-invasive directly, they have put and they have extubated. And they have used for CPAP, then the non-invasive they have done. Then NIPP they have done. Everything charts are telling, sir, here it is far, far better. But one thing you should remember, there is one beauty of the non-invasive HFOV. What is that? We do use NIPPB and CPAP for apneic spells. At the same time, with CPAP and NIPPB sometimes will cause apneic spells itself. How it is? Because like a CPAP abdomen, sometimes auto PEP will generate because of constant flow during the expiration. That overstretches the lung and splints the chest. That signals to the brainstem, I am done, my lung is full. That time central apnea will develop. At that same time, even larynx, pharynx will develop more, CO2 will wash out, and oxygen is too much, chemoreceptor will start. So these all those things can happen in NIPPV compared to the NHFOV. And this is a beautiful slide. Sorry, I used adult one. If we don't learn, actually I am still on life support. I just came by to do a feasibility study. Do you think you want your newborns to go there in the heaven and ask for it? Please, no. Learn it. Learn it. Nothing is impossible. This is all so many studies. I don't want to talk all these things, studies, whether it is better, because everybody go to the articles. There is the next slide, my presentation. Yeah, please. Just, I will take only 3 minutes for video. See, the map is 8. Delta P is 12. Okay, see the baby, see the cheek. See, very, very minimal amplitude, minimal delta P. See, cheek is not, any oscillation is not there. Go to the next slide. Next. Yeah, see, this is the, I just increase the same baby, delta P more, 24, map increase, just see the cheek. Okay. Yeah, go to the next slide. See, this is a SLE 6000. SLE 6000, it is a reverse flow valve. Next. Take my this thing. Just it is, I have taken from one more slide, PEP and HFOV. Next slide. Come. Please, I am taking you people for only 1 minute to my NICU, to show how, no need to just wiggle. Please, can you show?
Hi, Dr. Prashad. I think we lost Dr. Dinakar's connection.
Yeah, I think it's because, sir. Do one thing till he comes back. Please start the discussion part. Over to you, Dr. Razak. Dr. Razak, yeah.
Yes, I can hear. I just was trying to
A lot
unmute
of
my.
questions which has come up.
Yeah, there are lots of questions here. I hope we are able to answer that. So, Professor Manoj, it was very fun. It was very great presentation, and we're happy to hear from you. And I think you have really covered almost majority of topics on the concept of high frequency and volume guarantee. So I think from evidence standpoint, the evidence is very limited, as you showed.
Yeah.
And people out there who are using high frequency volume guarantee in their units, I think they should gather their data and start producing and publishing to show what it actually does in terms of benefits per se. And actually should start looking at trials. And the second important thing I would like to say from my side is where the high frequency volume guarantee is being used, I think those units should have a proper protocol in place to understand, because high frequency and high frequency volume guarantee are completely different. I hope we do that. So there are a couple of questions here. So the first question we have is, it said something about resonating frequency.
Yeah.
Could you tell us how exactly find resonating, and how would you actually identify it in clinical practice? Let's say you are ventilating a 1 kilo premature baby, and how do you know this is the resonating frequency for that particular infant?
Okay. Am I audible?
Yeah.
Okay. See, this is the basic physiology of lung. All the data we have are last century, 20th century, from if you really look at this thing, because nobody has really done any studies to look at the frequency of resonating lung thereafter. And most of the initial studies were from piglets, and then subsequently some of them were extrapolated. But I'll tell you another way to look at it, like the frequency at which you can go down, because the concept of gentle high frequency ventilation means the higher frequency and lowest MAP. But after a frequency, if you go higher than that, you will find negative results. Like in the conventional ventilation volume targeting, if you just target less than the physiologic this thing, you would be ventilating that space. So in the same way, so that is the lung. And by this is some convention probably set. So all term babies, when you start with 10. And preterm babies, maybe 34, 36 weeks, we start to 12. And then smaller babies, 23, 24, you always start with 18 or something like that. If you go to higher frequency, you would find that CO2 doesn't get washed out more, which means that is the best resonating frequency. So the values will be different. So this is just a concept. Smaller the baby, smaller the value. And if the baby's CO2 is quite high, you can start with a slightly lower frequency and then go on to that. But once you reach that, then don't go further.
Okay, I think that was clear. The second thing is again about the resonating frequency. So let's say if a baby has respiratory acidosis, very high CO2, there are two ways we can come down the CO2, either by increasing the amplitude or decreasing the frequency. And some of neonatologists believe that in these babies, we should use higher frequency and higher amplitude rather than lower frequency and higher amplitude because the lung injury is higher with lower frequencies. So could you tell your opinion on that?
Yeah, that's exactly what I was trying to say. See, like if you can manage with the highest frequency, that is a gentle ventilation. But the problem is, suppose you keep a high, say 12, and you start ventilating a 32 weeks baby, and you go up to, there is a limitation for your delta P. After which, because the delta P depends on the fine-tuned electrolyte balance, the sodium potassium channels and all these are involved. So if your electrolytes are not, even if they are perfectly normal, they are immature in a preterm baby. So after a point, you cannot increase the delta P and then wash more CO2. There is a limit. Whereas in such scenarios, you may need to, in desperate scenarios, we come down. And more so because if you convert babies at a later stage. If you follow elective HFO, it's different. But if it's a late rescue and all, probably you need to start there, and you can't get away without using lower frequency. Ideally, yes, I agree. You should use higher frequency to start if you can manage your CO2s. Usually, having said that, usually the problem is in oxygenation, not in ventilation when you are in those scenarios.
Okay, thank you, Professor Manoj. So there is one more question on lung protection and high frequency volume guarantee. So I think we all know that the way the lung protection happens in high frequency is either because of lower tidal volume that we use in high frequency, or second concept is the open lung concept. Now, most of the babies, they tend to maintain their CO2 levels by with tidal volumes of 1.5 to 2.5 ml per kg.
Correct.
Let's say if babies do not maintain CO2 with 2.5 ml per kg, and we need to go higher than that, do you think we will lose that benefit of lung protection?
Definitely, you will lose. Because that's what I said. If you are, all this problem is because we convert at a later stage. When you ventilate with higher than the total anatomical dead space, you are going to damage lung. Alveoli will get damaged. But then in desperate scenarios, you are pushed against the wall. You do whatever you want to rescue the baby. But you will definitely be damaging lung if you use HFO and ventilate or rather the vibrations reach the alveoli. It should not reach. It should ventilate only the dead space. That is lung protection.
Thank you so much. So the next question we have is from Dr. Raj. This is from Singapore. So do you think there is any effect of volume guarantee depending on the size of endotracheal tube diameter? If the tube is very long, if the tube is very thin, do you think you would set some different frequency for those babies?
I thought I mentioned this in my talk. Actually, these are parameters that you need to look at. Definitely the size of the tube, the compliance of the tube, all these are really going to affect. So probably one of the ways you can get around this scenario is by having a larger babies. When you use, this is my personal experience, when you use a term baby and initially itself you start on HFO, what will actually happen is that there will be a lot of especially if the baby is not quiet, you will not be successful. So I always start without volume, and then once you stabilize, I come back. But in preterms, most of the time you start HFO as an elective. You don't otherwise require, because these days even ventilation is also rare. But then if you start as an elective thing, so preterm babies, probably this problem is not there. Definitely the size of the tubing and compliance of the tube does matter. Definitely. And the ventilator also matters actually. So probably I would say, this is again, I stand corrected, my personal experience. VN500 is not as powerful as SLE 6000 as far as HFO-VG is concerned. Probably. This again, please don't quote me. And of course, Sensormedics does not have volume. So guarantee, even though we all love Sensormedics, it doesn't have volume.
Yeah. That is absolutely right. So we'll move on to next question. This is from Dr. Bharat. So he's asking, is there any difference between volume regulated HFOV versus HFOV volume guarantee? I don't know whether there's something called as volume regulated.
I think he is talking about an animal model in Leone, another ventilator. These are terminologies by just like ventilators, like SLE uses PTV for draggers, SIPPV for the newer one, the assist control. All these, so these are terminologies only. Basic concept is targeting high frequency tidal volume or not. These are actually terminologies. And take it from me, because I have done enough research on this, because this is my thesis for the MSc neonatology. Like, you cannot the thing is, the lack of evidence is a big factor. As you rightly pointed out, lack of evidence is a big factor. Right now, we don't have enough this thing to singly say. All are based on extrapolation, non-evidence-based practical methods suggested by authorities. That's all what I can say.
Yeah. I think there are only, as I said, there are only hardly two trials, and that the numbers are in 2 digits. So the evidence is far, far limited. So the next question is, I think, on...
but the thing is, even though when you say that, because that should not be deterrent for not using VG, because if you start using, you get addicted. And secondly, none of the studies, bench studies, animal studies, or human trials are reported any problem with it. So no adverse effects. Evidence has not really come up. So absence of evidence and evidence of absence are not the same thing, we all know. So that should not make us say, oh, that is not evidence-based, let us not use it. There's nothing like that. If you do that, you will never progress.
I think that's what is happening with us here. We are also getting addicted to high frequency volume guarantee. When we put on any baby here on HFOV, even at McMaster's, so we used to put on HFOV-VG because there are 2 important things with HFOV-VG, as you rightly mentioned. One is stable volumes, and second one is like auto weaning. So it's like, cruise control in a car. So people get used to, get addicted to it. So there is one more question. This is regarding HFOV-VG and congenital diaphragmatic hernia. And this is from Dr. Qureshi. So he's asking, can we use VG with HFO and CTH?
No, I have used actually, and it was, in 2 cases, I tried to use. One baby, the severe pulmonary hyperplasia, did not work. I became desperate. I took off VG and I ventilated. The other baby, it worked. So it can be there. If you can use HFO, you can use HFO VG as well. Only thing is, if your baby is not very stable, sometimes it will be very challenging. You have to be there, because the adjustments are much more with VG than without VG. So if you are there, you are not your registrar or your resident. If you are there, you can use. Otherwise, sometimes we tend to, take off VG.
So Dr. Manoj, do you use lower volumes because of one lung and the other lung is hypoplastic, or use the usual volumes?
Yeah, in CDH baby, we started with 1.5. We realized even that it was hyperventilating. So I brought it down to 1.3. 1.3 is what I used in that baby, actually. So probably I do not want to complicate by putting in other scenarios. 1.5 to 2.5 is a value for you to start. You need to titrate.
So there is the next question is from Dr. Pradeep. So he's asking, how do you set HFO VG mode? He just wants a brief explanation on that.
I thought I explained this.
Yeah, I think you did, but I think that's...
I didn't explain. So like, there are 2 ways. You first decide what is your target. So like, if you are going to do rescue ventilation, it may be better to not to use VG initially, get things steady and then use it. Sorry, can I continue?
Yes, Dr. Manoj. I think there's some trouble. Yeah, go ahead.
A semi-elective, not as a late rescue, then you can straight away start with. So when you're starting straight away with HFO VG, you set your target volume. You may be on the higher side. So term baby, I would start with 2 or 2.1. In a preterm baby, I would start with, depending on the gestation age, somewhere between 2.2 and 2.5, and then try to look at the other parameters. Amplitude, always you keep it high, because you don't know how much is, what is the conditional length. 60, even 60 you can keep. That is not the amplitude baby is going to get. That is the amplitude max. So it's like a PIP limit in your conventional ventilation. And then recruitment, de-recruitment, re-recruitment maneuvers for oxygenation, mean airway pressure is exactly same as without VG. There is no change in that. Only thing is, this is only change to start with. But you need to understand, if you cannot stabilize the baby with VG, it may be a good idea, because you have started late. It may be a good idea to initially not use VG, get things under control, and then keep on looking at that point. If you're not using, keep on looking at the measured panel, you will see that what is the tidal volume, what is the DCO2. Based on this, the moment baby is stable, you decide how much tidal volume you want to start on and put the baby. This is what I do. Others can share their experience with us.
That's great. So there's the next question is from Dr. Shweta from Andhra, and she's asking, I think you explained earlier than this, but again, so whether volume delivery is same in all machines or there's any difference? I think you told SensorMedics is somewhat strong.
We have showed the study where the SensorMedics was delivering with the same settings much more tidal volume than SLE. I showed the slide if you remember. So it is all the machines are not same. You need to know your machine. It's a basic principle. Whenever you talk about ventilation, you need to know your machine, and in that machine, what is your this thing. So if you're using, as it is, you cannot use SensorMedics for volume targeting. You can only look at that volume, this thing. So it is not the SensorMedics. You cannot. You can, as of now in a country. I mean, there are no 2-3 more machines that come up. Dinakara will be the expert on the newer machines, but then the machine that I have used are SLE 6000 and VN500, Drager VN500. Both machines reasonably similar. The thing. So SLE maybe you can use a little less, but then probably both are similar.
Okay. I think the other question we have here is, do you adjust flow rates for volumes? I think this is from Dr. Bala Subramaniam from Tamil Nadu.
No, actually, you cannot have too many variables in this. And as it is, as I said, flow adjustments in these two ventilators I mentioned are not a direct adjustments. They are way other things. So I don't usually do that. And but one thing you can actually you do that by your ratio 1:1, 1:2 ratio. That is actually going to indirectly affect. So 1:2 is what probably is more gentle. But then in these machines, except SensorMedics, as I mentioned previously, 1:2 may not be a good idea, especially if you are not using in early early indication. The earlier you start, late rescue and all, probably you should not. You can start with 1:1. So probably no.
Okay, that's great. I think the last question we'll have here is. How can I set volume guarantee in HFO in babies with PIE? This is from Dr. Syed from Delhi.
Great question. I think when I say the answer, please don't quote me, because there is nobody can give you there's no evidence as we are talking, but this is actually based on the extrapolating the concepts in conventional ventilation. So like PIE babies, you are not really worried about stabilizing them. You are worried about actually they are going to be stuck for some time. So it is a better idea to actually use lower tidal volume. But right away to say you start with a lower tidal volume, no, it may not be. So again the question is, have you started early? Have you converted early, or your baby was stuck on conventional and you're starting late? If you're starting late, you initially start with the same as the other one. If you're starting early, you can try slightly lower, maybe 0.1 or 0.2 ml per kg lower tidal volumes to start with. Remember, higher frequency and lower MAP are lung protective in PIE. So this is general ventilation. But whether you can achieve that depends on when you convert and all that. So you need to know, and then each case is different. So PIE is the very difficult one. Actually, just one last word on this. I mentioned the Martin Kessler Enomoto study, actually Japanese study, they were doing that because all extreme preterm babies stuck on ventilator for more than 28 days were the target for, were the ones. So this is the inference. What I said is the inference from that.
I think that's all the questions we had for you. And thank you again, Dr. Manoj, for the lovely presentation. It was great to have you.
Thank you so much. Thank you so much.
And again, we'll move on to Dr. Dinakara. I think we lost Dr. Dinakara. We lost your presentation somewhere. If you want to just finish up, and then we can go on to your questions.
No, please go ahead.
Okay.
Please.
Dr. Dinakara,
any questions are there for me?
Yeah, we have some questions here. Just before that, I'd like to thank you for the lovely presentation. Your concept on physiology on nasal high frequency were fantastic. And thank you so much for that. So we will go on to the questions. So this is from Dr. Samir. So he's asking, can I wean directly from invasive high frequency to non-invasive high frequency with same settings? And he's asking, how do you look? I mean, whether you will consider shaking of the body when you put the baby on non-invasive.
Yeah, directly from HFOV to the non-invasive, definitely yes. Definitely yes. Because when you are going to wean off from the HFOV, when mean airway pressure comes to the 8, or if it is extreme premature baby, 6 or 8. If it is a little bigger baby, 8. So mean airway pressure that I told you, delta P at least 15. So in a bigger baby, 15 to 20. Frequency as usual 10 is a better frequency. So I told you frequency, I told you amplitude, I told you mean airway pressure for preterm as well as a term, means a bigger baby. With FiO2 definitely less than 30%. With that, if all the systemic problems, CBC is normal, electrolytes are normal, other problems are not there, Newton is better, then definitely I do extubate the baby directly with non-invasive HFO. In fact, to tell you very frankly, now I have 3 ventilators with me. One is Fabin, then another one is SLE 6000, then Medine, that you people will be knowing that I had, but they have taken it back from us. Now the 2 machines are there with us. Non-invasive HFOV is far better, because the same thing you are going to connect to this, and baby will come out very, if it is necessary only, then I am weaning off to low flow oxygen if it is necessary only. Really, you can do it, and I am doing it because I have the machine. If the people doesn't have that machine, you can do it NIPPV, SIPPV, or CPAP. Yeah, over to you.
Thank you, Dr. Dinakara. I think what we also do is we extubate babies directly from invasive. We don't put on initial and then extubate. And what we do here, even when I was a master, was to extubate to either an IPP or CPAP. And if anything fails, we will have non-invasive high frequency. So the next question, what we have here is, can non-invasive ventilation prevent or increase intraventricular hemorrhage? This is Dr. Anirudh from West Bengal.
Sairam. Okay. Till now, I told you, I have not come across, really I have not come across, whether because I showed you, I think so my camera got something problem. Till now, even I put the delta P, that means amplitude, only cheek and the neck, little neck part should wiggle. That's all I'm going to put, because oscillator pressure ratio, OPR, it is still 0. Less than 0.15 or 0.4. If it is there, I don't believe chest should wiggle. That much amplitude I never kept. Until now, whether IVH will develop or not, in my babies, it is never developed. And only one article shows IVH in 3 cases with some problem was there previously for the baby. That is the reason. But per se, with HFOV, I don't know. I haven't seen, I never read any article. 1 article, 3 cases I saw. I don't know. Somebody, if you know something, please.
Thank you, Dr. Dinakara. I think the data is very limited to say that whether it increases or reduces. We don't have much clinical trials. So we'll move on to the next question, that is, do you use flow sensor in non-invasive high frequency? I don't think we use, but I'll leave it to you.
See, boss, one thing very clear, straight. Only synchronized IPPV, we need the flow sensor. Otherwise, nowhere in NIPPV, CPAP, or HFOV, we use sensor, because the sensor will work. I don't know, please sir, whoever asked, sensor will work on VTE. Sensor will work on VTE. means expiratory. On that expiratory and flow, it will give it in the, that is called VTHFE. On that, it will sense it how much to deliver, how much to not. So we should not use number 1 question. Here, Dr. Razak, one small, I will just add on to one thing. Volume guarantee and volume target. There is, because I heard Dr. V C Manoj was answering this, everything is looks same, but one thing, sir, very clear, Dr. V C and Abdul and people who are listening, volume guarantee will definitely take up the leaks from ETT or whatever the uncuffed ETT, then it will sense in 1 second, whatever the breath in 1 second in volume guarantee, like VN500. Definitely it is a volume guarantee. It will take the sense, and I don't know about SLE 6000, I don't know about Fabian because, and Leonie, Sophie, and there is one more thing. What is that? Even sensor medics, because non-HFOV and VDR4 Bronchotron, all these things, non-invasive HF and Medine CNO. I am talking about what is it? Volume guarantee, invasive mode. I am talking. Those things is not volume guarantee. It is volume target. That is the reason small babies sometimes giving the volume will be difficult. If you'll go to that machines, if you will go to inside that machine and study the how it functions, you will be shocked. So VN500, Dragger, Japanese machine, they do have that. And other machines, I don't know. Okay, thank you, sir. Next.
We have a few more questions. So this is from Dr. Karthik Nagesh. Dr. Karthik Nagesh is asking, after initiating nasal high frequency ventilation, how do you ascertain the adequacy of ventilation soon after that? When do you call it as failure of non-invasive high frequency ventilation? And how do you monitor babies on long-term nasal high frequency ventilation? This is
Sir, one by one, please, Abdul, one by one. I am not so intelligent. One by one, 1 minute, I'll write down. It's a big question.
Maybe I can repeat it for you. The first question is,
yeah, please, dear.
After initiating the nasal high frequency ventilation, how do you ascertain the adequacy of ventilation soon after that?
Yeah, 1 second. Initiating, ascertain. Okay. Number one, how you are going to monitor? Number 2, boss.
When do you call it as failure of non-invasive?
What is the second question?
The second question is,
number 2, failure. Then
failure of nasal high frequency.
Failure is second question.
Yeah, this third question is, how do you monitor babies on long-term nasal high frequency?
No. So I will first initiating and how you are going to monitor. I will take together. I will take first and second together. Then I'll go to the third one later. Number 1, sir, respected sir. See, number 1, how you are going to start the HFOV, sir? Map, whatever the map is there in your previous monitor. Example, CPAP, you have a map of 8. So you have a FiO2 of 60% if it is a rescue. CPAP, map is 8, FiO2 is 60%. I will take it if you are using that. Then suppose if you are using the MAP, what is that map or what is the PEP or map, whatever it is, sorry, PEEP. Whatever the PEEP you used or map you used, I will take that map, MAP map from NIPPV. Then I will take FiO2. That also I have taken. Suppose HFNC, same thing, sir, 8 I will take it. I will start 2 more than that. 2 more than that. Suppose if it is 8, MAP, what I'll start is, because extreme low birth weight or it is 1.2 to 1.5 kilo baby, I do use 10 MAP, number 1. Number 2, delta P, I already told 2 times more than that. I do start, I see the cheek and just below the cheek, neck starts, that part is wiggling or not, I will see. Said that dead space is covered, CO2 is washing out. Some amount, the next muscles, I told you cricothyroid or actinothyroid or actinocricoid, all those muscles are in comfort. I have started delta P. Then frequency, if it is, I will take the chest x-ray, if it is homogeneous or if it is a normal lung. If it is a normal lung or homogeneous, I do use 8 to 10. If it is a very, very small lung IT ratio, then I might use 12. So I used it, I told you. Delta P, I told you, frequency, I told you. Then I told you FiO2, I started with 50% or 60%. Then IT, I told you dictum is 1:1. Like the dictum of invasive ventilator 1:1. It's better because more volume is delivered. I have started. One thing, sir, as how to monitor. Please don't change the frequency. Number one. Number second, see that baby should be very comfortably. Wait for minimum 15 minutes. Check the SpO2 because it will show the SpO2 is 90 to 95%. I am comfortable. Then work of breathing, you know, delta P divided by delta V. That thing, work of breathing is decreased or not. If it is minimal, don't worry, sir. Just increase the PaWO, that is mean, by another 2, sir. Because whatever that I told you, oscillator pressure ratio will be less only. Need not worry with the delta P, sorry, the delta P. Even mean, just try to increase by 12. That work of breathing will definitely comes down, sir. With that, take care of secretions. That is the big enemy for Hfov. Because with Hfov, secretions do come, sir. So take care of that is the reason what I do in my own evidence base, my own practice. After extubation, I keep a in mouth because baby will cry or baby will open the mouth. So to prevent that and soothe the baby, I keep one pacifier with the gauze piece, and inside gauze piece, I'll make like a small nut. I showed you in a video. I'll keep it in the mouth, such that it sucks out all the secretions of the baby's mouth, as well as it closes the baby's mouth. Whatever I deliver mean airway pressure, whatever I delta P, it will go into the larynx and pharynx. Then that's what monitoring. SpO2 I monitor, work of breathing I monitor, BP I check, heart rate. You know that normal constant heart rate 120 to 135 to 145 is the normal resting heart rate for newborn. If it is increasing, that means baby is having problem. That is over. Sir, failure. I have increased, when I have increased the FiO2 more than 60%, like NIPPV. Then MAP increased to up to 18 or 20, 18 to 20, but there is nothing like failure of, like CPAP, there is a criteria failure. NIPPV, there is a criteria of failure, 25 or 30, like that MAP. Even Hfov, there is a criteria of failure. Okay, like that in non-invasive Hfov, I haven't read anywhere what is the criteria of failure, but the same thing if I am keeping it. So if you are going more than 20 for a preterm, very extreme preterm baby, or 25 for a bigger baby, mean with delta P as it is increasing, baby is distressed, not well, I intubate. But till now, once I extubated, I never intubated a baby, sir. Hfov is far better. Yes, sir. Next.
Okay,
Abdul,
so
you can tell me your experience.
Yeah, I think, as I said, in McMaster, we mainly use nasal high frequency when babies fail on non-invasive positive pressure ventilation. Some babies do better, some babies do not. And the main problem which we faced those days were too much gas in their tummy. That was the main problem, and that that distension is causing the problems with ventilation. That was the main problem we faced with high frequency. I don't know whether it's the same problem with there or you don't experience these kind of a thing.
Actually, I never had any problem with Hfov. More than 83 cases I have done Hfov. I never faced any problem with the tummy. I mean, tummy CPAP like that, CPAP tummy or HFOV tummy, because I usually keep this. Only thing is a secretion problem is there.
Okay. So we have few more
You
questions.
know any criteria of failure?
No, we generally, you know, in McMaster, we don't have criteria for failure. It all depends on the attendance discretion. We used to continue even at 60% and sometimes rarely 70%. But if the baby is requiring more oxygen than that, we used to ventilate. And as you said, we were using very high PEEPs, you know, like 17, 18, or the mean air pressure on the oscillation. But I don't think.
And one more thing is, I am trying to use, you know, SOPI. What is our person, Srinivas Murthy has made out one formula, SOPI like CPAP.
Yeah.
We are using it 0.2, more than 0.2 to 3, and more than that. That I am using, but till now I never felt. I don't know, boss. Really, I never seen any non-invasive HFOV failure. I never seen. Okay, next question.
So the next question we have is, what is the risk of nasal trauma and pneumothorax in babies on nasal high frequency? This is from Dr. Sidhu.
It is very Sidhu, I'll kill him. Okay, nasal trauma, it is common because see, I never seen any nasal trauma because I do use, number one is, I want to tell you here, Sidhu, very good question, sorry, very good question. Because if anybody uses nice Neotech Rams cannula, it is little tough and very sturdy. So amplitude coming down is less in that. And what is that? Whatever the sizes you need, you will get nice Neotech Rams cannula. It is a beautiful thing. It is made for actually, I am telling you, for non-invasive HFOV. But I am using the high flow nasal cannula Fisher and Paykel, or if it is bigger size. Always I told you I use a bigger this thing because it is anatomically placed, very comfortable. Always I put it, Deoderm and Tegaderm, both, and I never seen any nasal. Previously, when I was using Fisher and Paykel with that head bonnet and other things, I used to find much problems. And with nasal mask, I used to find many nasal depressions. But I left it. Even for my bubble CPAP, I use the same HFNC cannula, because bigger cannula that will do suffice and help for my babies.
Okay, so
yes, sir. Over to you.
Yeah, thank you.
Next.
So Dr. Sidhu has one more question. What is the role of nasal high frequency in pulmonary hemorrhage?
Pulmonary hemorrhage, yes, there is, I think so. He read there was one article in pulmonary hemorrhage with non-invasive HFOV. It is from, I think so, from India, and one article I have seen from Middle East. I have seen that article. So if see pulmonary hemorrhage, there are definition is there, boss. If it is a massive, definitely intubation is better, or invasive HFOV is far better than anything else. Because if it is more than 2 lobes, we will call it as a massive pulmonary hemorrhage. If it is a minimal aspiration, yeah. If it is a minimal, if it is because of the sister doing something, or at the time of birth, intubation, tracheal damage, or something, if you are not confirming it is that non-invasive HFOV is better, still you think pulmonary hemorrhage, then you should rule out the cause, whether it is a PDA. Definitely PDA needs a more PEEP. HFOV will work better with more amplitude. Like instead of using 12, use it 16 to 18. Instead of delta P, that is amplitude, instead of 30, use it around 40. Then frequency, it doesn't matter here, because pulmonary hemorrhage, once again, time constant is short, or sometimes it is mixed disorder. Mixed. So use it 10. It is very tricky, but I never applied pulmonary hemorrhage with non-invasive HFOV. This is the thing, but you can use it. Yes, over to you, Abdul.
Yeah, thank you, Dr. Dinakara. We have one more question from Dr. Divya. I think you have already answered this. She's asking mouth closure is needed or not in HFOV, and how wiggle will help in HFOV.
I told you, sir, last time only, mouth closure is not so, because if you close, better delivery of amplitude will be there like CPAP. If you don't close, we might lose some pressure, number one. So mouth closure, always there is a mouth strap, chin will come, mouth strap, chin strap, something is going to come. If you are working in a village or a periphery or government hospital, if it is expensive, what we do is, if the patients are poor with our, like this thing who are coming, so I do just tie the, what is that, gauze piece to the, chin to the head. That is enough to close the baby's mouth. And one more thing, baby, to soothe the baby, to comfort the baby, I put little glucose, 5% or 10% glucose solution in that pacifier, that what I showed you, gauze piece. I'll put it in the mouth, baby automatically closes its mouth, number one. So mouth closure is better to deliver a delta P and a MAP, that is good. Number second, wiggling. I told you very clearly, all the articles, take any article, even including Mukherjee's. He too mentions, even in his talk, when he came, mentions just upper chest wiggling we should see. But need not be. My 87 cases, I never keep the amplitude up to chest wiggling. I keep only, what is it?
I think we lost Dr. Dinakara's connection. Dr. Prashant?
Yeah. Just, yeah. I think we have covered most of the questions.
Yeah, I think we covered almost all. There were a couple of things on the interface, but most of them were done, I think.
I think he's come back. He's messaging. Yeah, if anything is there from your side, you can share your experience as well.
No, I don't think. I think most of our speakers have covered almost everything, and we had lots of interesting questions. And I thank you and all the members of NNF Organizing Committee for allowing me to be the moderator today. Thank you, Prashant. Over to you.
Yeah, thank you. I think we had a very detailed discussion of the HFOV, both non-invasive and volume guarantee, in detail and in depth. So I'm sure all the participants have enjoyed, and that's the reason why we had so many questions, almost 24 questions. So I got tired of forwarding it. I would like to thank all the participants and showing such great interest in learning. It was a wonderful session. I would like to thank Dr. V C MANOJ, Dr. Dinakara, Dr. Abdul Razak for being part of this session, for great session. Thank you very much. And I request all of the participants to log on to the next upcoming program, that is on HFOV, acute deterioration, application, procedures, monitoring, nursing care, and nitric oxide method of calibration, initiation method, and contradiction, which I've put. And I've already shared the link as well. And if you missed this particular session, you can still watch this session in our Facebook page, NNF Karnataka chapter Facebook page, and we have a YouTube channel as well. NNF Karnataka.
Prashant,
Yeah. Yes,
any
sir.
questions were there last?
This was the last question, what you answered.
Okay, thank you. Abdul, thank you very much. And Dr. V C MANOJ, thank you very much. Thanks for coming. Dr. Bhatia, sir.
1 second, sir. 1 second.
And Sidhu. He's asking questions here.
Sidhu, 1 second, sir.
Okay.
Yeah.
Unmute all.
Sir, good evening,
Hey,
sir.
unmute.
Good evening.
Somebody was lifting the hands, no?
Yeah.
Yeah.
Naresh.
Yes. Somebody was lifting the hands.
Yes,
Dr. Naresh?
myself, Dr. Naresh. Sir,
Yeah.
what is the cost of the nasal high flow machine, sir?
What is the cost for?
My NHFO machine.
Sir,
Like,
nasal HFOV, the cost is, sir, it is how your capacity of bargaining, sir.
Yes.
Bargaining capacity.
So the
Hey,
maximum
Sidhu, don't
bargaining
laugh,
capacity.
please.
So the maximum bargaining capacity.
Yes, sir, bargaining capacity. No. Medine CNO, they will charge 8.5 to 10 lakhs. If you will bargain, they will give you for 5.5 lakhs. But if you will go for a Fabiana ventilator, if you will go, it is around 12 lakhs because you can use invasive, non-invasive, volume guarantee, all the ventilator. If you will use it for the, what is that, SLE 6000, definitely 18-19 lakhs. 18-19 lakhs. Sir.
Sir, does the result in IUGR baby differs in this type of ventilation?
Sir, IUGR baby or preterm baby, both are same, almost same, sir. But the problem here is lung, sir. Problem here is lung. IUGR baby also, if the baby is not breathing very well, you should see what could be the reason. Whether it is hypoplasia of lung, whether it is infection, whether it is severe polycythemia because of the repeated hypoxia in utero, whether it is having polycythemia and lung abnormality, you should see, sir, because microthrombi is very common in severe IUGR babies. Microthrombi. That is the reason those babies without even PDA sometimes do cause after 3 days severe pulmonary hemorrhage. That is the reason IUGR baby is deceiving babies. You should be careful, sir. Even you can use, sir. HFOV everywhere you can use, sir. Next.
Sir, is there any center in India who is giving training regarding ventilator used in the newborn?
Yes, sir. Sir, you can come to Neo Gurukul, ask Dr. Prashant Gowda. You please request him. Dr. Prashant Gowda is our NNF secretary, and Dr. Kutresh and Bidri. And here our joint secretary is there, the great person Sidhu Charki. You can ask him. He will definitely train, sir.
Is there any app available for this? Are there any?
Yes, sir. Dr. Prashant Gowda is. Yes, sir. You can come. You can contact Dr. Prashant Gowda. Neo Gurukul team is there, and NNF Karnataka ventilator team is there. We do teach ventilator for 1 week, sir.
Yes,
Yeah.
sir.
I have sent my number to you, sir. You can send a message to me. I'll store it and we can directly talk.
NNF Karnataka is having ventilator. We have a ventilator training. One branch is there. We will teach, sir.
Thank you very much.
Yeah,
Thank you very much.
Send my number. Please store it because once the session goes, you won't be able to store. I've sent it in your chat, Zoom chat.
Yes.
Okay. I think we have covered, Dr. Sidhu.
Yeah, Prashant, I wanted to add a few words. Thank you, Razak, for being there.
Thanks.
And I think Wasim is also with us, right? Prashant, can you
he was
unmute
also
Wasim
with us.
Patel?
Yeah, he was there. I don't know whether he's still here.
No, he's still there. He's still there. I can see him in the list. Prashant.
Yeah, I'm trying to unmute him.
Yeah, please. It would be nice. There are two of our friends. Wasim is my MBBS batchmate together.
Singh, can you unmute Wasimuddin Patel?
So, Dr. Dinakara, sir, thank you for a wonderful talk. Hi, Wasim. Hi. Nice to see you, man. Wasim, your audio is mute. You have to unmute.
So, Singh, can you unmute?
Yeah.
Done.
Hi, Wasim.
Can you hear me?
Yeah, we can hear you now, Wasim.
Yes,
Welcome to Neo Master E-Class, NNF Karnataka.
Thank you. Very
Nice to have you
informative
here.
session. I enjoyed a lot.
How was your experience?
Nice points.
and nice practical points to get from the webinar, right? And it's nice initiative from you.
Dr.
people.
Dinakar sir, Washimuddin is along with Abdul in the Abu Dhabi, I guess. Both of them are together there.
No, we are in Riyadh, yeah, sorry.
Riyadh, sorry, they are in Riyadh. Yeah, and, Prashant, you need to unmute Dr. Dinakar. Wasim, we have been doing this new mastery class since last 1.5 months.
Yeah.
I would request you and your team to be a part with us so that we can spread our wings much more. Dr. Monica Kaushal has been with us. I think we have a lot of friends in every forum. So it will be nice to have Abdul, you, many others as speakers, as moderators with our team. Our secretary, Dr. Prashant Gowda, will be there, and I will be there. We all, Dr. Dinakar sir is there. We all will be there with you guys. We can do it in a joint venture.
Okay, fine.
I think you can log in with us regularly. It is just 2 to 3 talks weekly. I think Dinakar sir, it was a wonderful talk, wonderful experience listening to you again after a long time. You have taught us really well. A lot of queries have been sorted out. No, sir, I am genuinely telling you this. I think, Abdul, what's your opinion? I think we all enjoyed this session.
I think it was great. I love the physiological concepts by Dr. Dinakar. And I'm glad to see that so many babies have been put on nasal high frequency. And
exactly. He said 83 babies.
After hearing Dr. Dinakaran's talk, now we are becoming bold to put babies on nasal HFO. Usually we get afraid to put the babies on nasal HFO. Now I think we should try more now. Yes, definitely.
Wasim, you would be...
Abdul, wait. Sidhu.
Yes,
Sidhu.
sir. Yes,
Sidhu.
Yes, sir.
Just Abdul, see this. Just I am telling you, please bring the things there and show that this thing we will bring. Allenu kattan size agbiಡ್ತೀನಿ. ಈಗಲೇ ಬಾಬು 1 second. ಅದೆಲ್ಲಕ್ಕೆ ನಾನು ಕಟ್ಟನ್ ಚಾರ್ಜ್ ಮಾಡ್ತೀನಿ ಬಾ.
Wasim, we have been using non-invasive HFO in Bijapur also, by the grace of Dr. I think it is his confidence which has made us do that.
It's great to hear from you.
Yeah, we have actually 6,000 here. I think, he's showing some baby on non-invasive HFO. Yeah.
Yes, great.
Beautiful.
Dr. Dinakar.
Yeah.
So are you planning to conduct any clinical trials at your center looking at nasal high frequency as a primary support?
To tell you very frankly, dear friend, I am not so luxurious here because I don't have fellows and I have almost always 15 babies. I am myself and Dr. Girija, we are only 2 people. If I am taking now, to tell you very frankly, it is very difficult because I have my own hospital now, almost coming, it is 20 crores, big project hospital. Really, I don't have time. Otherwise, see here, I am telling you simple mouth, you can people see, simple mouth, baby automatically closes the mouth and see this much wiggle is more than enough. No IVH will develop. See, just to see, I will just increase the delta P, how baby will be discomfort, you see. Now I kept it 22 only. See, just see. See, do you think you need so much wiggling? Just wait for 1 minute, baby will start moving the leg.
I think
we lost the video, I think.
No. I think somebody is intervening, Prashant, I guess by now. It's already 2 hours. I think again we lost Dr. Dinakar sir.
Yes, okay.
Abdul, Wasim, it would be again a request to you guys to be a part of this. Whenever you guys are free, we can chat on WhatsApp also. And Prashant, we can add Wasim also in the NNFK group along with Abdul in our NNFK WhatsApp group. We can add Wasim as well.
Sure.
Yeah, that would be nice so that they'll be in regular touch with us. And any trial, anything, I think, Razak, you can guide us.
Yeah, I think so. We are very interested in clinical trials and studies.
Yes.
And I mean, I think we have some expertise in running the trials. And you know, we can look at study design and help you with randomization, data collection, how to, you know, those kind of things we can provide from our end. So I think you have to look at the centers who can do this.
See, right now in my center, medical college, we have 2 multi-center trials with 5 institutes going on. One is on mass, one is on therapeutic hypothermia. Non-invasive, I don't think so anyone is doing as such. Only Dr. Dinakara sir has got a huge number. 83 was a good number, what he has tried as such. Because most of them don't have the luxury of the machine per se. SL is 6,000, costs around 28 lakhs, if I'm not wrong, which has got non-invasive HFO. Fabia costs around 20 lakhs. So it's a little difficult on cost part. Prashant, you wanted to say something?
Yeah. I think, ma'am, Dr. Sana.
Yes. Good evening, ma'am.
Hi, very good evening. Nice to see you. It was an excellent session. Lot of learnings from the talk. Though we have our HFOV. And hi, Dr. Razak and Wasim.
Hello, madam. Nice to see you after a long time.
Hi. So excited.
Yes,
Can you hear me?
Yes, ma'am. We can hear you.
Can you hear me?
Yeah. It's good.
Yeah, so nice. They were our wonderful PGs during those days. I'm really missing you people.
Yeah, we were lucky to have you as our teachers in our residency. That was our like
so
base.
Excited to see you guys. That's why I came in today. Yeah, and they were our best hardworking PGs. Prashant, Sidhu.
Yes, ma'am. Yes, ma'am.
Yeah. Very hardworking. Can you hear me? I can't hear your voice.
Yes, ma'am. We can hear you. We can hear you.
No, ma'am. We can hear you, ma'am. I've worked with both of them, ma'am. Wasim was my
They were very, I was actually in touch with Razak. He sends all the nice articles now, multicentric trials. I'm so proud of you guys. I keep telling my present PGs, now the trend has changed. 2020, after COVID, it's still worst. You know, the attitudes of our postgraduates. These 2 guys, during the peritoneal dialysis, whenever we needed, they used to come and do in the nights. I still remember those.
Yes, ma'am. Right.
So nice. Please come down. We have 6 VN 500.
Wow.
Oh, great, ma'am. Great.
Razak.
Yeah, wow.
Now one baby is PPHN is on VN 500 HFOV. We are oscillating. But nasal HFOV I have not tried. Maybe definitely we can wean from there to here.
And we can use with VN 500. We have used with VN 500.
Okay, yeah, maybe. So a lot of learnings from this session. Nice to see you guys.
Dr. Sana madam will use from today.
Yes. Namaskaram. Excellent, Dr. Dinakar, as usual.
Kandu, you should start using now.
Yeah, of course. Yes. The baby will be weaned from that to a nasal HFOV. Yes.
Thank you. So otherwise Sidhu will come. Sidhu will run.
No, sir. So the best part about learning is all of us can meet each other, learn new things every day. And it's been a practical thing. And Razak, one thing what I wanted to request you was regarding meta-analysis. We can have a version of yours.
Yeah, I think we can have as I think Dr.
Prashant sir and Prashant Gowda sir.
We can have one full session on meta-analysis. I can.
Dinakara sir, he is really good with meta-analysis. He has already come out of.
No, I know that Abdul has written for IAP Neocon some book. I heard about him.
Yes, sir.
So today I am seeing him.
Yes, sir.
And he has written some book, no?
Yes, sir. I think we can have Abdul as well as Wasim in our future webinar plans once they are free and based on our schedule. We'll be happy to listen to you guys because you are our alumni. It's always nice to have you guys. And as Madam requested, if you can come back, it will be nice.
Hopefully.
Okay. Nice talking to you guys.
No, Abdul, very nice. Wasim, very nice. Thank you.
Thank you, sir. Thank you. Very nice presentation, sir. Congratulations.
Thank you.
Sir.
Over to you, Prashant. Over to you.
Thank you, Abdul. I think regarding the research.
I can hear you, Dr. Prashant.
Can you hear me?
Yes, I can hear you.
Yeah. So we will discuss that personally about the trials. I will give support, and we've got a lot of expertise. We have how it goes. Okay, we will discuss personally what kind of help you would need. We will talk about the yeah. Thank you, Dr. Wasim, for joining. Thank you.
Thank you, Dr. Prashant.
Have a great Sunday.
Pradeep, Prashant.
Yes, sir. Yes, sir. Yes, sir.
See, my PGs wants to tell hi to you people.
Oh. I think we have met most of them, sir. We have met most of them.
Sidhu,
Yes,
wait.
yes,
Sidhu, especially he want to tell hi to you.
No, sir, we have met most of them. They have been our wonderful colleagues in Carnio.
Still she remembers your dance.
Sir, we are in webinar, sir. Thank you. We are on a webinar. Nation is listening.
Bye.
Thank you, sir. Thank you for having you guys. Bye, sir.
Thank you, Dr. Prashant.
Our great person. Bye, Abdul. Bye.
Bye.
Bye, Razak and Wasim. See you.
Bye, madam. Thank you.
Bye. See you. Okay.